am so blessed to have been invited to be part of the counseling and care team, the executive board here at St. Paul's. Of course, it also helps those of you that are members here that I have to shout out my own family members. So my brother-in-law is Mike Westendorf. My sister, Melissa, is sitting right over here, and one of my nephews, Thomas, is also sitting over there. So I'm very proud, Uncle Nick, and getting the chance to be able to present to you guys. I appreciate you guys with the support coming tonight as well. So again, as Christine mentioned, I work full-time for Rogers Behavioral Health in West Dallas, and for a number of years, I served our Oconomowoc facility in residential treatment, substance abuse, and co-occurring disorders. Just recently, within the last, I would say, year and a half, and I was working nights doing that. So those of you that have worked nights, you only can imagine what difficulty that presents. So finally, I got my substance abuse certification, and I transitioned over to our West Dallas location just because I needed to start getting hours accrued towards my certification. So now what I was missing out in patient care, now I'm actually doing that full time, and I love it. This is my mission, this is my calling, and I am so blessed just to be able to share this with you guys tonight. So with those handouts that you have, the first one that you have here is about anxiety. And I think sometimes just mentioning the word anxiety, okay, can kind of fill us with, oh my gosh, you know. We have various different ideas about what anxiety is, how it feels, things of that nature. So without any further ado, let's actually start there. Okay, so one of your first questions on your sheets that I have for you here, and I'm going to ask for audience participation, okay? I want to make sure that I don't have to start calling on people, though, all right? So the first question comes down to, what does anxiety feel like for you? Go ahead, feel free to start shouting out suggestions. Fear. Yeah, absolutely. Right? Go ahead, Christine. Sick to your stomach. Absolutely. Or nauseous.
Butterflies, a trembling voice.
Yes, absolutely. That can happen even when you give presentations like this. Right? What are some other feelings that come up with anxiety? I think, and I hear this a lot from my patients because the material that I bring to you tonight, I do this on a regular rotating basis with my patients on the inpatient level. So these patients are coming in basically raw. They're coming off of their substances, okay? So their emotions are going all over the place, right? They're sky high, they can be really low, okay? So, and their inpatient stay is generally like 7 to 10 days, okay? So I don't have much time with them. So this information for them, okay, is kind of real basic. Some may go through this 2-3 times, okay? But, you know, the cool thing about it, what I get to do, even if I've seen my patients 10, 15 times, at least I still see them. I tell them that, at least I still see you. Even though you haven't fully gotten it yet, even though you haven't gotten sober yet, you never know what going through this group, what this little nugget might be that might turn the switch on for you, that might be able to give you some hope. So we've got a number of different symptoms that you guys have given me here, okay? Butterflies in the stomach, I feel nauseous, I feel faint. I get a lot of these same symptoms from my patients, okay? Maybe a sense of feeling overwhelmed, feeling frustrated. Those are common ones I hear too. And fear, of course. Fear is a huge one.
Is there a medication or
Well, as a matter of fact, I'm going to get to that. So hold on to your question for me, okay? So we have what anxiety feels like. Now the second question to get into, how do you typically respond? How do you typically respond when you feel anxious? Now normally, for my substance use patients, they'll say, well, I go use, okay? And that's the typical response, okay? Some other things I might hear from them is, well, I might go self-harm. Self-harm can mean a number of different things, okay? They might isolate. That's a common one. They might engage in other risky behaviors, other compulsive behaviors, such as compulsive eating, compulsive gambling, okay? You don't have to use your imagination with some of these things, okay? What are some other typical ways that we tend to respond to our anxiety? Yeah?
I have a question. Can anxiety be an ongoing, perpetual feeling, or is it when you're giving a presentation and you get a little uptight about it?
So, these are all really good questions, okay? So, I'll address that too in just a little bit here, okay? What are some other responses that you guys have in regards to anxiety? Short fuse, yeah. Getting irritated, right? Getting upset, getting irritated. Avoiding that thing that makes you anxious. Yep, and we're going to talk about that here too tonight, right? I didn't quite get that one. Yeah, crying, absolutely, right? Anxiety can feel overwhelming, yeah. Excellent questions, okay? Excellent responses too. So let's move down here. What is anxiety, okay? So the American Psychological Association says that anxiety, guess what? It's just an emotion. And this emotion is characterized by feelings of tension, worried thoughts, and physical changes like increased blood pressure. People with anxiety disorders usually have recurring intrusive thoughts or concerns. And they may avoid certain situations out of worry. Okay, this comes from the American Psychiatric Association 2018. Okay, it involves physiological changes, okay, accompanied by psychological responses, especially doubt about a potential threat or our ability to cope with it. So anxiety involves apprehension about a future threat, whereas fear is a response to an immediate threat. Anxiety is a threat detection emotion, whereas fear is a threat response emotion. So if you flip over, okay, we've got two great examples here. I don't always like to use this one necessarily with my patients, okay, but I think for the sake of what we're talking about here, I think it'll be appropriate, okay? An example of fear, okay? I see a bear in the woods, I feel afraid, okay? I run, that's the flight response, okay? Makes total sense because that is a survival skill, right? That our bodies have, that we were created with. So in this example, actual danger is present. The fear assists me in acting quickly to flee the situation. On the other hand, we have an example of anxiety. So I have to give a presentation at work. I feel extremely anxious for whatever reason. I call in sick. Now that's a flight response. That's also an avoidance pattern, which I'll talk about in just a little bit here. Okay? So in the example with giving a presentation at work, actual danger is not present. I feel uncomfortable, and I avoid the situation. It's not only unhelpful, but it can create additional problems, such as getting a poor performance at work. Now, some anxiety or nervousness in this situation is common, could be helpful. If you weren't nervous or anxious at all, how would you prepare for the presentation? Would you prepare at all? Okay? Any questions about kind of fear and anxiety and how it works in relation to one another and how they're different? Okay. If you have questions along the way, feel free to raise your hand. Okay? Now, some important facts about anxiety, and I haven't forgotten about your questions, okay? So the first fact that we have, number one, is that anxiety, guess what? It's normal. Now, when I say anxiety is normal, I'm referring to baseline anxiety that we all have, okay? So everyone experiences anxiety at times, it says here. It's normal to feel anxious when you're on a roller coaster or before a job interview, okay? Or you got to give up here and give a speech to somebody. So baseline anxiety is normal. We all have it, okay? Fact number two, fear and anxiety can be adaptive. So fear can trigger, we already talked about this a little bit, your fight or flight system in your body, the stress response, okay? Your body prepares to defend itself, much like the bear example, okay? Anxiety can also increase preparedness for important events, okay? So there's a relationship between anxiety and performance, and that's what this fancy schmancy bell curve here is, the Yerkes-Dodson curve, okay? It shows the relationship between anxiety and performance, okay? So if you look at arousal, another word for arousal would be anxiety on the bottom, okay? Going from low to high, and performance going from weak to strong, okay? So let's use this as an example. Let's say that it's the first snow in Wisconsin, okay? Even though we have been driving through snow every single year for who knows how many years, whenever the first snow comes, we always lose our minds here, right? Even though it's an inch or two of snow, okay? We start reacting like our brothers and sisters down in like Texas or down in Florida, right? Who've never seen snow before, okay? So now I have to drive for the first time in snow, okay? Technically, okay, it's not dangerous, okay? So let's say I have to go to, driving in that snow, I have to get to an important appointment, okay? And I have to go through an area, right, that might not be the best area, okay? So as I start to go up the curve, okay, I get increasing attention and anxiety as I do this, okay? So maybe as I drive, right, I'm starting to kind of fishtail a little bit, okay? I'm in this neighborhood, I don't really know where I am, I can't see the street signs, okay? Maybe I start to see some areas that are boarded up, okay? Maybe I start to see some individuals that I'm not sure about might be, safe individuals kind of on street corners and what have you, okay? But we go all the way up to the top of the curve, and bam, we say, woohoo, I made it to my destination, right? I made it to my appointment, okay? That's where we have optimal anxiety and optimal performance. So no matter how high my anxiety may be, I made it to my appointment. I got there, okay? The exact opposite can happen at the same time. So I can have impaired performance because of strong anxiety. Let's say I'm driving in that neighborhood, okay? Same scenario. But all of a sudden now, I come to a stoplight, somebody asks me for directions, and I slug them in the face. Yeah, hard to believe, right? But it does happen, okay? So that would be an example, right, of strong anxiety impairing my performance, right? So it can work in both ways. So we can see that anxiety is related to performance. I mean, you can take sports figures too, right? Sports figures going into like a major championship, like, you know, the World Series, going into the Super Bowl, okay? You have athletes that perform really well. You know, they become like World Series MVP or Super Bowl MVP, right? No, I'm not going to mention Tom Brady, okay? But, I mean, you talk about anxiety and performance, and when those individuals, right, when they're under high anxiety, they still perform like they get into this zone, right? That would be optimal anxiety and performance, okay? But you could have the same thing happen to an athlete in that situation as well, and they could totally bomb or tank, okay? Does that make sense to you guys? This whole idea of anxiety and performance and fear and anxiety being adaptive. Okay. So, question, can you think of an example where some anxiety may have helped your performance or the performance of someone else? I kind of just gave you the answers for this one, but I'm interested to know what you guys might have to say. Yeah?
Like a fireman, going to a fire to rescue a child, or would be a very heightened thing, try to get that kid out.
Yeah, absolutely. Firemen going to respond to a scene, right? And child is in the house, right? Got child screaming, get me out, right? Fireman goes in, absolutely. I can guarantee you that anxiety is going sky high at that point, right? But he's got the training, and he knows what to do despite his feelings, okay? Now I'm getting into a little cognitive behavioral therapy here, okay? What may happen if someone entered a job interview with zero anxiety? What do you think about that? Yeah, they could be overconfident, absolutely. Yeah, go ahead, Mike. Yeah, could work that way too. Yeah, Karen? Yes, they could come across very cocky. Mm-hmm. Right. Of course, I had a patient tell me that maybe just a couple months back that he had a situation like this, and it was the most relaxed atmosphere. He had his feet up on the table, right? He went into this job interview. The guy, you know, he apparently interviewed with, right, was just as relaxed, and where you wouldn't, in most situations, you know, that wouldn't be acceptable, but apparently, the patient got the job, okay? So each situation is different. Yeah?
I'm thinking of a situation where a couple is out on their first date and the guy misreads the situation and thinks he's in a position to be aggressive and blunders.
Yes. Absolutely. How many guys in here have been through that situation before? Right? Okay. Excellent. Fact number 3. Now, I get mixed opinions on this one, okay? Especially from my patients, okay? They'll tell me, all right? Fact number 3, anxiety is not dangerous. What do you think about that, you guys? Depends on the level. I would agree with that. Anybody else? Anxiety is not dangerous. Yeah, Mike. Yeah. Yeah, exactly. So we could definitely say, in and of itself, right? Even though anxiety feels uncomfortable, it's not dangerous or actually harmful to you. Okay, I would say unless, okay, maybe you've got something like pre-existing conditions, right? One of my coworkers told me about a patient, one of her younger patients, that had a heart condition. So any amount of anxiety could set off like something related to like heart palpitations, which could lead to eventually like a heart attack, okay? So, but in and of itself, like Mike, you had mentioned, right, because we said fact number 1, that anxiety is normal, right? along those lines too, I did have a patient, much like was already mentioned by you guys. They said two different things, okay? You have normal baseline anxiety, but then you have excessive anxiety. So she's like, I'll agree with you, Nick, on half of that statement. I said, okay, that's fair, that makes sense, okay? So baseline anxiety, generally not dangerous. But once we get into excessive anxiety and like pre-existing conditions, that's where it can be, or become dangerous, okay? Even though it may feel uncomfortable, okay? So anxiety is not dangerous, but it signals potential danger, okay? And of course the problem lies into, and I'll get into this, right? The problem becomes the behavior, okay? How am I responding, okay? And for most of my patients, right, they haven't known how to respond. So they've always had, or the majority of the time, they've had not so good responses, okay? Because maybe they didn't learn those things, okay? Didn't learn those coping skills, strategies. So now they're in the process of learning those. And this goes into fact number 4, that anxiety, guess what, doesn't last forever. It may feel that it'll last forever, okay? But it doesn't, okay? So even though, like I said, it feels that way, it's temporary and will eventually decrease when there's no actual threat. And this is what I want to highlight, even if I don't do anything, right, to try to make it go away. So the body actually can't stay in a heightened state of arousal 24/7, 365. It just can't, okay? It's got to come down on its own. And we call that the rest and digest process of going through anxiety, okay? So there's going to be a beginning, there's going to be a middle, there's going to be an end, eventually, okay? It may take you 2 days, it may take you 2 weeks, but eventually it's going to come down, okay? Because the body wants to be in homeostasis, as they call it here, big fancy word, okay? Parasympathetic nervous system, okay? Go ahead, flip over, another flip. Fact number 5, anxiety is mostly anonymous. So in other words, I can't tell if you're anxious. Well, I kind of can because I'm trained to do that. But in most cases, I can't tell. Just because Pastor Bonock, might be up here bouncing his leg, right? Or might be, kind of wringing his fingers, right? Doesn't necessarily mean that he's anxious, okay? Maybe that's just how Pastor Bonock, channels energy, okay? So that actually has helped me with my patients so that I don't assign assumptions to my patients, okay? I would also say that with this notion that anxiety is mostly anonymous, right, they kind of feel, individuals feel like they're under a spotlight and everybody's looking at them, which usually isn't the case, okay? This is a little bit of a hard saying, but I use this with my substance use patients, okay? This idea, everybody's looking at me, everybody's judging me, blah, 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 okay? I want you guys to pay attention to this, okay? Maybe a little hard, but I want you to hear this anyway. What you think someone else is thinking about you is none of your business. I got a couple laughs on that, which is good, okay? Because those with substance use primarily, okay, have been doing that for so long and have gotten into so many destructive patterns, one of the primary signs or symptoms of that in relationships with those individuals that they've been in, those enabling relationships, right, is this sense of people-pleasing and codependency, okay? And that being said, there's a lot of enabling going on, okay? And so that's why I bring up this notion to my patients, okay? If you really want to begin to heal, okay, you have to begin to start looking at that part of yourself, okay? And start asserting yourself too. Not aggressively, okay? But this can be learned as well in order for us to take back our power from anxiety. Using I statements. When you, I feel, because. Okay? We call that interpersonal effectiveness. And it works wonders. Is it easy? No. No, it's not easy. Especially if you haven't done it. Okay? It feels really uncomfortable. But as you practice it, it gets better and better. Okay? Sir, I wanted to go back to your questions again. Maybe this would be an appropriate time to try to answer those. One, I believe you said, was anxiety. Is it long-lasting, was it? What's that? Yeah, is it long-lasting, or does it just kind of stay, right? So, again, with anxiety, okay, and with mental health diagnoses, okay, the length of it, which I'll also get into here, depends on a lot of different factors, okay? We don't know a lot of those, okay? But individuals that may be dealing with anxiety for a long time could have an underlying disorder where it just might be more persistent, okay? Someone with, for instance, like with generalized anxiety disorder, okay, which is excessive anxiety about a number of different things, okay? You could have someone like that, like an adolescent, maybe develop that at 15 years old and have that when they're 35. I would definitely say that would be longer lasting anxiety, okay? For others, it just might be a momentary kind of thing, okay? Just because it's a momentary thing doesn't necessarily mean that it needs to be medicated or talked about. I think when we're talking about anxiety, especially when anxiety begins to become a problem, okay, is when it becomes excessive, right? And then life begins to start becoming unmanageable as a result, okay? And we start taking avoidance pattern techniques or risk-taking behaviors as a result. Does that help? Okay. And the second question you had, was that related to specifically medication? Except I don't actually remember your question. So you had said, does medication help with anxiety? Was that like the substance of that question? Yeah. So there are a number of different medications, yes, that can help with anxiety. However, those medications are not a happy pill, okay? It's not a cure-all, right? It's not like you go to the Matrix and Morpheus says, hey, Neo, take the red pill, take the blue pill, okay? One's going to stop your anxiety, one may not, okay? Or maybe they both will, I don't know, you know? Take them both. So medication-assisted treatment definitely helps with a lot of those things, okay? But we encourage our patients not only to focus just on the medication aspect, but also other coping skills that we teach them throughout their clinical pathway, okay? So stress response, I already talked about this a little bit, okay? The fight or flight response, okay? So stressors. Stressors basically are any kind of life-changing event, okay? Any person, place, thing, whatever it might be, that could be a stressor that cause anxiety. And then the body, okay, with the parasympathetic nervous system responds, okay? Question here, what are some examples of the physical changes experienced with the stress response when you feel you are in danger? Remember, your body kicks in. So it's trying to survive at this point. We get heart rate increases, respiration increases, okay? Cortisol and adrenaline go to those parts of the body. Blood goes to those larger parts of the body to prepare it for action, okay? Like I was saying in the beginning, this is where the body prepares for action in the face of real danger. Do you guys have some examples of where it would not be adaptive to experience the fight or flight stress response? Any examples there? Sure. So what are some examples or situations it would not be adaptive or most effective to experience the fight or flight stress response? And then the other portion of that, what are some examples in which it would make sense? We already kind of talked about that, you know, the bear in the woods, right? Yeah.
You're a pastor and you're nervous about preaching, it's not good to leave the church.
Pastor Bonock, do you want to talk about that one? Okay. Yeah, there you go. Okay, one example. Yep. Yeah, I would say that it would be probably in instances of more closer along the lines of actual danger. Yeah. So this question now becomes, okay, when does anxiety become a problem? Okay, as I was saying before, okay, when it gets to the point, okay, where avoidance, okay, becomes a problem, avoidance patterns, okay, and avoidance patterns are always two things. They're always risk-taking, and they're always excessive. Okay, so, for example, as it says here, okay, when anxiety increases in response to a non-threatening event, such as giving a presentation at work, okay, your stress response tells you to flee, okay, so you call in sick. Okay, then the question becomes, what did I not learn or experience as a result of using that avoidance pattern? And we've all done it to one degree or another, okay? So, and the curve says here, okay, even though it felt like the anxiety basically was more or less what I thought going to kill me, okay, it may have felt that way, but it wasn't going to kill me, okay? It limits my ability when I use those avoidance patterns to learn that the threat wasn't dangerous. In other words, I short-circuit the process, that natural process, by going to an avoidance pattern. I don't allow the body to come to rest and digest on its own because I short-circuit it, okay? Because whatever that avoidance pattern was, or whatever that stressor was, may not have been dangerous. So, go ahead and flip over to page 46, okay? So try to think of anxiety as this, okay? As being a smoke alarm system. A smoke alarm can help protect us when there's an actual fire. However, sometimes a smoke alarm system can go off when there really isn't a fire. And they give the example here, such as burning toast in the toaster, right? Like a smoke alarm, anxiety is helpful and adaptive when it works right. But if it goes off when there isn't any real danger, it's not only scary, but it can be exhausting, okay? The other thing, too, I talk about with my patients, okay, those that maybe haven't learned these coping skills or these coping strategies, okay, and they start using avoidance patterns, or they started using avoidance patterns early, okay, in relation to these stressors, okay, we can actually condition ourselves to respond to these stressors that might not be dangerous as dangerous, right? We can condition our bodies to go into fight or flight when that's not the case. And as we do that, over time, we can actually make ourselves sick, bodily and mentally. That's an instance where it becomes a problem, okay? And then we know with avoidance patterns, okay, we can create new triggers too, right? Just like it said here. Even I might think, you know, giving a presentation like this tonight, right? If I ran away from here and said, "No, sorry guys, I'm not interested in presenting tonight. Forget about it." You know, I don't show up. What new triggers is that going to create for me? Don't have to use your imagination too much to think about that. Yeah.
Don't you think it's oftentimes the anticipation of doing a work presentation or something, you know, a couple of days before is more terrible than when you actually are in the situation you're
Yeah. What did President Roosevelt tell us years and years and years ago? Right. The only thing we have to fear is fear itself. Yeah. That's one of the other things I talk about my patients with, too. This whole notion of catastrophizing, right? We love to catastrophize for whatever reason, okay? I think the absolute worst thing before the actual worst thing probably isn't going to happen, okay? But you can see, especially in the pattern of addiction, how these things, how these thought patterns and cognitive distortions, right, hold us up and can prevent us from moving forward. So some common types of anxiety here. Specific phobias, okay? Phobias of specific triggers. I've heard new ones that I actually hadn't heard of before. So one of my coworkers said, fear of bridges. Japhyrophobia, I think it's called, okay? Individuals can't actually cross bridges, okay? There's a bridge over on the East Coast over the Chesapeake Bay. They actually have drivers that are willing, it's like a suspension bridge, I think. They actually have taxi drivers that are willing to take people across that bridge because they just can't go across, okay? Many, many years ago, it's one of my favorite movies. It was produced and opened a year before I was actually born. So the movie Jaws, right? Perfect example, okay? 40 some odd years later, people are still afraid to go into the ocean, okay? Or there's the fear of the open ocean itself, okay? Fear of spiders, that's a big one, okay? Social anxiety disorder, I just heard you ladies whisper that maybe up here, okay? This is anxiety in social situations, especially related to fear of judgment or embarrassment, right? Kind of like that spotlight idea. People are looking at me. Okay? Stop looking at me, folks. Remember what I said earlier. What you think others are thinking of you is really none of your business. Okay? We do a lot of work on the residential side with our patients with some of these phobias, okay? Or you could call them unwanted thoughts, okay? A lot of these things can relate to OCD as well, okay? Having some of these unwanted thoughts in our patients, we call those obsessions, okay? And then the way they relieve that obsession is through a compulsion or a ritual, okay? So, again, one way to think about that is having germs, right? An OCD for germs on your hands, okay? You have such a fear of germs that you go wash your hands 50 times a day. Okay? But then you still feel after that 50th time that you still got germs, in the crooks of your fingers. So then you go wash your hands 50 more times until they bleed. Okay? That would be an example of OCD. Okay? I jumped ahead a little bit, but we'll go back now. Generalized anxiety disorder, right? This is excessive worry about a number of different things. Doesn't matter what it is. Okay? This could be crippling, right? Anxiety. And the individual not knowing how to break free from that. And then, of course, there's panic disorder. Okay, this is a common one with my patients, too. Recurrent, unexpected panic attacks or fear of having additional ones. I don't know for any of you that may have experienced a panic attack here. I know I have. It was a number of years ago. It was basically like I stood still, and I couldn't break free from it. And then, these other ones here, which I just kind of talked about, right, while not considered anxiety disorders, in the diagnostic manual, our fancy DSM-5, diagnostical manual of mental health disorders, okay, we got OCD, and then we've got post-traumatic stress disorder. You hear post-traumatic stress disorder all over the place, okay? So with PTSD, those are exposures to actual or threatened death, injury, or sexual violence, okay? It could be reminders of the trauma, changes in thoughts or mood, increased feelings of depression, maybe disassociation. When I say disassociation, I mean the individual is actually experiencing that event, right? And they're actually removed from it. They're kind of like staring off into space, okay? Until we have some kind of grounding technique maybe that we can use with them to bring them back into the present moment. You had already mentioned this, PTSD with like EMTs or firefighters, right? Military personnel, okay? Especially infantry, right? So how do we effectively deal with anxiety? How do we manage it, okay? Out of all this talk about anxiety, okay? My patients love this when I tell them this, okay? It's never about eliminating it, okay? Because most of the time they want to eliminate it because they're feeling like crud when they come into inpatient, okay? So they want to get rid of it. They want a year's worth of recovery in a week's time. So no, guys, it doesn't work that way, okay? So it's not about eliminating it, because remember we said that anxiety is normal, but it's managing it. So go ahead, flip over, okay, to our last page here, okay? Got a couple different things that we can do, okay? So our goal, according to anxiety and performance, right, is that we have moderate or an adaptive amounts of anxiety in situations where this is appropriate, but not to have overwhelming and excessive anxiety that impairs our functioning. So that's one. There are several other ways that we can manage anxiety. If it becomes overwhelming and excessive, we can use relaxation skills to calm the stress response, okay? I love doing this with my patients. So we have what's called respiratory control, and we also have deep muscle relaxation. So respiratory control, and these have to be practiced, okay? We generally say like 30 minutes a day, okay? Respiratory control, primarily, we want our patients to focus in on that when they're approaching situations where there's almost like intense panic, okay? Because at that time, we are not focusing on our breath. We're breathing from our chest, right? And at that point, we're not breathing from our diaphragm. So we tend to hyperventilate, and we don't realize that we're doing it to ourselves. That's why you see people with the brown paper lunch bags, right, breathing into them, right? Because they're getting their oxygen back, recycled back to themselves. They also, individuals talk about like an over-breathing kind of sensation too, like they're choking, okay? I joke with my patients, I tell them, okay, you guys, as we're doing this, I don't have to rescue anybody, I have to save anybody, but you know I love you guys and I'll save you if I have to, okay? So respiratory control helps us change the stress response pretty much immediately, okay? And it works. The other is deep muscle relaxation, okay? This one, we can kind of use a little bit more on kind of a regular basis, especially if we're having trouble sleeping at night, you know, those of us with insomnia, right? So progressive muscle relaxation, we are tensing and relaxing various different muscle parts of our body in sequence, okay? So it helps with a general sense of relaxation and well-being, okay, especially when practiced regularly. I had a patient just a couple months back say, she said, because I could tell that she'd been through the groups a couple times, and she actually said, Nick. I said, yeah, what is it? And she said, you know, I couldn't sleep last night, and I actually did your deep muscle relaxation, and I got to sleep. I said, wow, you just made my day with that. See, again, no matter how many times I may see my patients, no matter how severe their withdrawals or symptoms, as long as I still see them, that's why I love doing this work. So relaxation skills, okay? Changing the stress response, respiratory control, okay? It can also be helpful for us to be aware of avoidance in anxiety-producing situations and do your best to face situations that may be challenging but not too overwhelming. right? So that it doesn't turn into long-term avoidance. So we don't go to those avoidance patterns, okay? One person's avoidance pattern may be another person's coping strategy, like exercise, for instance, right? Okay, so let's say one of you has an argument with your spouse, okay? You don't want to go make an apology, okay? All right, I hear you, I understand, I get it at times, okay? So let's say you go to the gym, okay, before you are ready to make that apology, okay? You want to burn off some steam, kind of get your thoughts together. But then guess what? You don't do it because you stay at the gym for 4 hours, okay? Until your spouse goes to bed. That's an avoidance pattern, okay? You did get a good workout in for 4 hours, right? But it didn't address the initial trigger, right? That unpleasant emotion that you feel because you know you have to make an apology to your spouse, okay? And then we've also got problem-solving strategies in general, okay? That's where it's so helpful to have support, okay? Whether you're in 12-step, okay, and you have a sponsor, or you have other people in your fellowship that you talk to, whether you have a therapist, okay? Whether you have a psychiatrist that you meet with regularly, okay? There's so many different coping strategies that we can do to actually manage our anxiety so that we don't have to become a slave to it. So again, finally, just some final thoughts about this whole anxiety thing, right? I love what the facts say, okay? Oh, and two other things real quickly about anxiety. There's two types of anxiety. This isn't in your packet, so just kind of keep it up here for me. The first, okay, the first type of anxiety involves, and kind of like the problem-solving technique with it too, it involves something that I can do to help lessen that anxiety, okay? So let's say I'm running down the hallway, I bump into Pastor Bonak, and knock him on his rear, okay? For whatever reason. Okay? I go to him, I offer an apology to him. Okay? He says, "Oh, Nick, that's fine. Kind of hurt, but I forgive you." Okay? I manage my anxiety pretty well. Type 2 anxiety would be that same situation, but guess what? Pastor Bonak doesn't accept my apology. Okay? Then maybe I have to sit with that anxiety for a little bit. Okay? And then maybe I have to use some other coping skills. Okay? So, type 2 and type 1 anxiety. The biggest thing I want to leave with you guys as we talk about this, right? There's a myriad of different ways to be able to help us cope. We don't have to be a slave to it. I know we've all gotten into that, but we have options available. We have our therapy, our individual therapy. We have medication-assisted treatment, problem-solving activities, bodily responses that we can do, all to give us hope, once again, so that we can begin to have some sense of freedom over this. All right, I think that's the end of the anxiety talk. We'll take a little bit of a break. What is it, 20 minutes? Oh yeah, we have a question, yeah. Okay, so question was with a panic attack, okay? What's the best thing to do in the middle of a panic attack and what to do to prevent them from coming on in the future? Okay, I already kind of mentioned this, so medication can be a huge help, okay, in that area. I would say, much like I had mentioned here too, again, when you're in the middle of it, okay, we know that our breathing is not diaphragmatically centered at that point, okay? So the more we can get our focus on our breathing down into our diaphragm versus in our chest, right? Because we don't want to hyperventilate, because that's going to make the situation worse, probably, okay? The quicker we can get to our breathing in a sense of calm, the better off that we're going to be, okay? If respiratory control doesn't work, then maybe I reach out, maybe I make a call to someone, a support that really understands the situation and can talk me down in their unique way, okay? And a number of those other different coping strategies that I mentioned as well. Does that help? Yeah, you're welcome.
What would you say the expectations of dealing with people with dementia and Alzheimer's when they are continually full of anxiety and unreality of things?
So when someone has dementia and when they're uncertain of, unrealities and cognitive distortions and things like that, and their memories going. Unfortunately, I don't have enough experience with dementia and like Alzheimer's to speak about that, but I would think that, a lot of the, hopefully somewhat a good majority of the coping strategies that we mentioned, I think what those individuals need there at that point in time is maybe some redirection because they don't feel like they can make choices at that point, and maybe just have someone there to listen to them.
We have an Alzheimer's support group for caregivers of Alzheimer's people, and each individual, when they have to deal with that situation, for them, it's the first time something they didn't anticipate or know, and they go into these anxious periods.
Mm-hmm.
And so our goal is to assure them that they're not the first people to have this experience, and that there is support and sympathy, and they can talk
Right.
freely about how they feel, and it seems to be a stressor reliever.
Yeah, so from what it sounds like what I'm hearing is that in a sense to kind of normalize it, right? And to not put a label or stigma on it. Yeah, Mike.
How much has the counseling field looked at things like personality and research that's being done today? I just came out of another one that Patrick Duncioni, who's a huge researcher on these things, and one of the three speakers that for people who have a higher, almost like a higher anxiety that risk assessment things, they actually have a delay in reduced level of serotonin.
Mm.
Part of their personality. And so that it would seem as though in a number of these strength finders and enneagrams, there's suggestions here that some of us are wired to respond to anxiety in a certain way.
Mm.
And so I'm wondering if some of this could also be helped by understanding how God really wired us.
Mm. Yeah. Mm-hmm. So Mike had brought up this idea with what is the counseling field doing as far as kind of looking at anxiety and like individuals being maybe wired in a certain way, right? And this notion of serotonin, okay? It's interesting that you mentioned that, Mike, because that is, as far as I know, that is actually one of those medical statistics that some individuals use up serotonin more quickly than others. Why that is, how that is, I don't know, okay? But we do have medications that certainly help along those lines, and I'm glad that you brought up too, Mike. This notion of, in a sense, being able to see, maybe especially from a spiritual aspect, how maybe our Creator or higher being kind of wired us, and kind of how that all fits in, and so. It really is kind of a fascinating journey. We don't have all the answers yet, but I know that they're kind of looking into that. Yeah, Pastor Bonock.
Yeah, I was going to add that neuroscience that we're talking about in psychology is very big right now, but I think we're about, on a scale of what we know, we're about like we're 2 days old
Yeah.
compared to what there is to know and understand when it comes to all of this. You think about the human brain, you think about how different we all are, and how that all kind of works together. It's very complex, but there is a ton of research being done on that
Oh, hereditary, yeah, absolutely. Yep. Yeah, with anxiety and depression, yeah, especially those that suffer with it, those really are the two biggest risk factors, right, is genetics and environment, okay? Any other questions? Does that help, Mike, in a way? Hmm. Mm-hmm.
And that's why people themselves, medications, it's a crapshoot. And you go to a psychiatrist and they say, well, try this.
Mm-hmm.
But you can try, I mean, I tried something depending on what my different group was.
Right, right, yeah.
Everybody, chemically, everybody's so different. It's not like some diseases where we know exactly what we can give somebody because it's acute. We know exactly what to give somebody to, for having a heart attack.
Mm-hmm.
Really getting issues like this. One medication helps one person and the next person makes them they can't sleep.
Yeah, exactly, right. And we have to, those are some of those things that we have to be concerned about as side effects too.
Would you say there's more anxiety in the world today than there was 2 or 3 generations ago, like World War II here?
Well, I definitely think with, I know we have a statistic on that, especially now, just with COVID hitting, right? We know that especially our students, right, and our other mental health patients, right, there has been a definite rise, right, in anxiety and depression and suicide rates, right, just because of the isolation associated with COVID. Moving on to depression, okay? Now that you got your snacks, now that you got your water, okay, we're all ready to go here. So go ahead and pull out your handy-dandy sheets on depression, and I actually have a separate one, okay, that you guys don't have. Okay, so depression, okay? What is this depression thing? So it's common, okay? It's a mental disorder that presents with depressed mood, loss of interest or pleasure, feelings of guilt or low self-worth, disturbed sleep or appetite, low energy, and poor concentration. Okay, so that's what it is. Okay, go ahead, flip over. We know that individuals, in and of themselves, right, we occasionally feel blue or we feel sad. But these are usually short-lived, pass within a couple days. When you have depression, it interferes with your activities of daily living, okay? And it can cause pain, consequences. So it's a common, but it's a serious illness, okay? Go ahead and flip over another page for me. So depression is the leading cause of disability as measured and the 4th leading contributor to the global burden of disease. This is a little bit old, okay, in 2000. Okay, they say by 2020, which was just last year, okay, it's projected to reach 2nd place of all the rankings of DALYs. DALYs are disability adjusted life years for all ages, okay, both sexes. And depression is already the 2nd cause of disability adjusted life years in the age category of 15 to 44 for both sexes combined. So what's the prevalence of this whole thing? Okay? Depression doesn't discriminate. Okay, it comes in persons of all genders, ages, and backgrounds. It affects about 121 million people worldwide. It's among the leading cause of disability worldwide. It can be reliably diagnosed and treated in primary care, and fewer than 25% of those affected have access to effective treatments. That's a big number too, okay? What are the different forms of depression? Okay, we've got a number of different forms here, okay? So major depressive disorder, okay, or major depression, okay? So the core feature of major depressive disorder, okay, is either depressed mood or loss of interest in most activities nearly every day for 2 weeks. So in order for you to be diagnosed with major depressive disorder, you have to have a total of 5 or more symptoms present, with one of those symptoms being depressed mood or loss of interest in most activities. Okay? So other symptoms included could be changes in appetite or sleep, okay, feelings of guilt or worthlessness, recurrent thoughts of death or suicide, difficulty concentrating or difficulty making decisions, indecisiveness, okay? So that's major depressive disorder. Then we have dysthymic disorder or dysthymia, okay? Big fancy psychological term here, okay? This is also known as persistent depressive disorder, okay? So persistent depressive disorder involves many of the same symptoms of major depressive disorder, okay, but it just tends to be longer lasting. So in order to be diagnosed with persistent depressive disorder, you had to have had major depressive disorder, remember, keep all these straight now, okay, for 2 years, or experienced depressed mood most of the day for more days than not, for 2 years, with 2 or more additional symptoms present while they're feeling depressed. Okay? I know that's a lot of words there. Okay? So those really are the differences between major depressive disorder and persistent depressive disorder. And then number 3 states we have minor depression. Okay? So minor depression is this. Minor depression doesn't need full criteria, or it doesn't meet full criteria for major depressive disorder. But you have to have at least 2 depressive symptoms present for a longer period of time. Okay, so that's minor depression. Some subcategories of minor depression are psychotic depression and postpartum depression. Psychotic depression involves some kind of psychosis along with it, okay, such as hallucinations or delusions, okay? See a lot of this in some of my patients coming into inpatient, right? They may have a substance use disorder, but they may be in psychosis, okay? So we have to deal with both of those. And then we have postpartum depression, known as the baby blues, right? This comes after childbirth. This comes to mamas, okay? Mood swings, crying spells, okay? Does any of that sound familiar? Those of you that may have had postpartum depression, okay? And then there's seasonal affective disorder, okay? This is mood swings, this is crying spells too, okay? So this is a very real thing, right? When we come upon winter, it gets dark early, right? Individuals struggle with that. Some of the treatments for that, okay, we have those light-sensitive big lights, right? People have, you know, next to their bedside table or they're next to their study table or wherever, and so they have that shine on them for a couple hours a day, okay? It actually changes brain chemistry, okay? And then number 4, you guys have heard this one too, bipolar disorder, okay? This is also known as manic depression, or there's extreme shifts in mood here. Okay, treatment for this is usually lifelong. some signs and symptoms of depression. The individual is persistently sad, they're anxious, or they feel just empty. Feelings of hopelessness or pessimism, feelings of guilt, worthlessness, or helplessness. They're irritable, they're restless. Loss of interest in activities or hobbies once pleasurable, including sex. Fatigue and decreased energy. And then we have signs and symptoms continuing on here. Okay, difficulty concentrating, making decisions, remembering details, insomnia, excessive sleeping. Okay, we know that excessive sleeping could also be an avoidance pattern, right, for anxiety or depression. Okay, overeating or appetite loss, just not interested. Okay, thoughts of suicide, suicide attempts, which Erica is going to be talking about in a little bit here. Aches or pains, chronic aches or pains, headaches, cramps, digestive problems that do not ease even with treatment. Okay? And then we have this idea of illnesses coexisting with depression too. Okay? We call this with our patients that I treat, we call these co-occurring disorders, okay, or comorbid disorders. Okay? Usually, we find that substance use, okay, for them is the primary disorder, but it's not uncommon for like anxiety or depression to come alongside. Okay, then it's kind of like, well, which came first, the chicken or the egg, right? Did you start drinking because you were depressed, or were you depressed first and then you started drinking? Okay, well, in the big scheme of things, it doesn't really matter. I mean, it's helpful to know, but it's like, what are we going to do, right, to be able to help you manage and cope better, okay? So we have PTSD, we have OCD, panic disorder, social phobia, GAD, or generalized anxiety disorder, and we've got other serious medical illnesses here: heart disease, stroke, cancer, HIV, AIDS, diabetes, Parkinson's disease, okay? That kind of goes back to a little bit maybe what Mike was talking about. So now you're gonna ask this, okay? This is kind of like the $64,000 question. What are the causes of depression? Unfortunately, we don't really have a perfect answer to this one, but we do know, okay, that really the two biggest risk factors, okay, for causes of depression are genetic or hereditary and environmental, okay? So if grandma has it, okay, if great-grandpa has it, you know, if mom has it, somebody has it, okay, I'm probably going to have the gene for it. Okay, that doesn't mean I'm doomed, right? That I'm never going to get help for it, okay? But it just puts me at a higher risk, okay? Environmentally, okay, this could happen in the environment, such as like poverty, right? Could happen in environmental situations where maybe there was trauma, okay? Individuals might not have had the ability to cope with those stressors appropriately, okay? Stressors in general in the environment, other stressors that I haven't mentioned. Then we have socio-cultural factors, okay, and situations, relationships, personality, okay? So now we get on to management here, okay? Already talked about this a little bit. Antidepressants, okay? Primarily work on brain chemicals, neurotransmitters, serotonin, norepinephrine. Other antidepressants work on the neurotransmitter dopamine, right? Dopamine is that, you know, it's that cuddle drug, right? Okay? That is released from the brain, okay? Those natural rewards, those natural highs that we get, right? From like exercise, sex, caring for our young, okay? When we're depressed, those things tend to get less. Selective serotonin reuptake inhibitors, SSRIs, okay? They list some of the more popular ones here: Prozac, Zoloft, Lexapro, these are the brand names, okay? Paxil or Celexa. commonly prescribed for depression, okay? And then we've got good old tricyclics, okay? They're not as powerful, but they're not used as much today because of potential side effects, okay? And then you've got some examples there, like nortriptyline, and imipramine. And then you've got MAOIs, okay? They're the oldest class of antidepressants, okay? Cases of atypical depression, okay? But you have to avoid certain foods and beverages such as cheese and red wine, okay, which contain a substance called tyramine, okay? And then finally, in addition to our medication-assisted treatment, right, because it's not a happy pill, okay, we've got other therapy, like talk therapy, psychotherapy, CBT, cognitive behavioral therapy, okay, restructure negative thought patterns, okay, maybe cognitive distortions as we call it, okay. CBT, cognitive behavioral therapy, focuses on changing our behaviors first, and then our thoughts and emotions will follow.
What about vitamin D, the sunshine vitamin? Isn't that a kind of a more simple fix than these?
Yeah. Yeah, that's interesting that you mentioned that because in just seeing some of the doctors' work, especially on the residential side before I transferred over to the inpatient side, found that a lot of our doctors were prescribing more vitamin D to a good majority of our depressed patients, right? That, again, the science proves that, right, like a good dose of vitamin D actually works, right? Because we get that from the sun, right? Yeah, that's a great point. Exactly. Okay? So CBT, okay? Then we have interpersonal therapy, okay? Interpersonal therapy helps people understand and work through troubled relationships that may cause their depression. That's where we get into interpersonal effectiveness skills, okay? And then in more serious cases, okay, where medication and psychotherapy doesn't help relieve a person's symptoms, then we have ECT, electroconvulsive therapy, okay? That may be used, okay? It is not like those old horror pictures that we see, you know, from the old horror films, right? That, you know, a person's head's gonna blow up or fall off, you know, as a result of ECT therapy, okay? Doesn't work that way. It's much more humane and managed at this point, okay? Any further questions before I hand it over to Erica? I want to make sure and give her enough time here. Okay, fantastic.